All right, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. This is going to be one of the capstone episodes on our critical care vasopressor and inotrope series. We're going to really compare. We got a whole bunch of ways in which we're going to compare all these drugs. Most of this is going to be kind of silent study. There's no good way to present all these comparisons, but we have multiple tables here that we're going to kind of pause and let you look at. And then this study guide, as well as practice questions, will be on our Patreon page for members, so you can definitely access it in that sense. It's linked in the episode description. But we're going to go through a couple different ways to compare these. One is going to be a mechanism of action comparison, looking at each drug: Norepinephrine, Epinephrine, Dopamine, Phenylephrine, Vasopressin, Angiotensin II, Dobutamine, Milrinone, Vasopressor, and Midodrine, looking at their receptors and key actions. There then will be a dosing overview of all these drugs, a hemodynamic effects table, and metabolism half-life table, clinical pearls on each one, which we will talk about, and then a quick comparison table where all this is kind of put together into one super table. And at the end, what we are going to go through, which hopefully will be helpful, is a bunch of practice questions. So the summary here is this will be kind of a comparison of all these drugs. Most of this will be us pausing and letting you look at all these comparisons, as well as accessing this on our Patreon page. But then stick around, because we are going to go into practice questions on all these vasopressors and inotropes at the end of this. So quick reminder, none of this is intended to be acted upon as medical advice. Stick around to the end of the episode for the full disclaimer. Also, we'd love for you to check out our Patreon page, where we post a bunch of stuff related to study guides, practice questions, little kind of blogs and FOAMed stuff that we enjoy. We also have a podcast platform and obviously our YouTube platform, so we appreciate y'all. Check those out if you're interested. No further ado, vasopressor and inotrope comparison. So first thing is mechanism of action overview. So this is agent, primary receptor targets, and key actions. And a way in which you can help organize this in your brain is going to be adrenergic or catecholaminergic vasopressors: Norepinephrine, Epinephrine, Dopamine, Phenylephrine, and then at the bottom, Midodrine. Those are the vasopressors. And then the catecholaminergic inotrope is Dobutamine. These are all vasopressors and inotropes that work on catecholamine receptors, alpha 1, beta 1, beta 2. This is in comparison to the non-adrenergic or non-catecholaminergic vasopressors and inotropes: Vasopressin, Angiotensin II, Milrinone, and Levosimendan. If you're listening to this in podcast form, it's probably best done in video form, because we're not going to go into all the details that we're showing you. So definitely hop over to the YouTube version of this if you're interested. So we'd recommend you guys categorize that in your brain: catecholaminergic versus non-catecholaminergic. And then you can see all the different receptors: alpha 1, beta 1, vasopressin, AT1, PD3, troponin sensitization, all that good stuff, and then what you expect to see based on those things. So this is table 1. Table 2 is the dosing overview. These are all kind of theoretical or soft dosages. We'll kind of just write soft here in quotes. These are not absolutes, but they are important. The other things to note is that some of these have different dose-dependent mechanisms of action, right? Epinephrine at lower doses tends to affect more heart rate and contractility, and at higher doses tends to be more of a vasoconstrictor. All right, same thing with dopamine, although we don't use it very much. Beta 1 effects that affect the heart, increasing heart rate and contractility, tend to be 2 to 5 micrograms per kilogram per minute, whereas alpha 1 vasoconstriction effects tend to be 5 to 20 micrograms per kilogram per minute. The other things to notice on this dosing is that the Milrinone and Dobutamine, and Levosimendan for that regards, tend to have this option for bolus ? But we do not do or recommend bolus. It can cause hypotension for these ones. And then Angiotensin II, you can titrate up to 80 nanograms per kilogram per minute for a handful of hours, but then you really got to come back down to 40 nanograms per kilogram per minute. All right, obviously you can pause here and look at dosing as you see fit from this chart. Next one is hemodynamic effects. This is a very complex table, but it is helpful in terms of what increases or decreases MAP and SVR, what increases or decreases heart rate contractility and cardiac output. So we'll let you all pause it here and take a look at that. Metabolism and half-life, probably not as important. The huge things to note, though, are Levosimendan sticks around forever. 80 hours for one of its active metabolites. Midodrine also sticks around the oral vasopressor 3 to 4 hours. Milrinone can stick around 2.5 hours, especially in patients with AKI. You got to be careful because it can dose accumulate in those patients. Vasopressin sticks around 10 to 35 minutes, so longer than a lot of the other ones. Norepinephrine, Epi, Dopamine are minutes. Angiotensin II and Dobutamine are minutes, but some of these do stick around a little longer. Clinical pearls and when to use. So these we are going to just talk about quickly. So norepinephrine is first line in septic shock and really in most shock states other than hemorrhagic or hypovolemic. Epinephrine can be an add-on for refractory shock. It is first line in anaphylaxis as well as ACLS and cardiac arrest. And then it's sometimes nice in patients who are septic with septic-induced cardiomyopathy because it does have a little more inotropic effect. Dopamine we don't really use. The one time in which I suppose you could consider it would be low-dose dopamine, 2 to 10 micrograms per kilogram per minute in patients with bradycardia. Phenylephrine, we're not huge fans of in general, but some people do use it if you have a patient in shock with tachydysrhythmias, so like septic shock with atrial fibrillation with RVR, because it might limit the amount of norepinephrine you use, and norepinephrine or anything with beta effects are going to increase your tachydysrhythmia risk. Vasopressin is second line in septic shock, so usually add it on to norepinephrine when your norepinephrine is somewhere from 0.25 to 0.5 micrograms per kilogram per minute. We sometimes put it on a little lower when you're at about 15 micrograms per minute of our practice pattern. Angiotensin II is looked at as a salvage agent at this point for kind of refractory vasoplegia. It's usually kind of a third line or fourth line agent. So when you have catecholamine resistant vasoplegia. Now, this is a newer drug. There's going to be more evidence coming out on this. The first big trials, the Athos 3 trials in 2017. So lots more to come on this in the future, and we'll see if there's expanded use for it. Dobutamine is an inotrope. We use it in cardiogenic shock or acute decompensated heart failure. Similar to Milrinone. Milrinone is a little better for RV failure because you get a little more pulmonary vascular vasodilation. And Milrinone is better for patients on chronic beta blockers because Dobutamine acts through the beta receptor. So if those are blocked, Dobutamine won't be as effective, whereas Milrinone acts through the PDE3 receptor pathway, so not affected by beta blockers. Levosmendin is not available in the USA. It's a calcium sensitizer. And then Midodrine is an oral vasopressor that some people use to try to wean off IV vasopressors, but whether that works or not is still unclear. Here's a quick comparison table with a whole bunch of stuff on it. We're not going to read it, but it's hopefully kind of a nice summary. We'll let you pause here and look. And then last but not least, practice questions. So what we're going to do is we're going to read the question and the possible answers. We'll then pause there and say we're going to go into the answers. And if you need more time to think about it, please pause the episode at that point because we'll dive right into the answers after. All right. We're going to start with beginner, then we'll go into intermediate questions, then advance. Question number 1, beginner. Which of the following vasopressors is least likely to increase heart rate? A, norepinephrine, B, epinephrine, C, dopamine, or D, phenylephrine? All right, pause here if you need to. The answer is D, phenylephrine. So phenylephrine is a pure alpha-1 agonist. It has no beta activity. And it can even lead to reflex bradycardia. All these others have at least a little beta-1 receptor activity, right? So norepinephrine is primarily alpha-1, but does have some beta-1. Epinephrine has beta-1, followed by alpha-1, depending on the dose. Dopamine we don't use anymore, but also has beta-1, followed by alpha-1, depending on the dose. So phenylephrine is the only pure alpha-1 agonist. Midodrine, which is one of the oral vasopressors, is a pure alpha-1 agonist as well. If any of this is confusing, definitely check out our other episodes. We got episodes on all of these different drugs. All right, beginner question number 2. What is the primary reason norepinephrine is first line in septic shock? A, it increases renal perfusion. B, it lowers lactate production. C, it has potent alpha-1 vasoconstrictive effects with limited tachycardia. Or D, it acts directly on V1 receptors. All right, answer, pause here if you need to. The answer is C, norepinephrine C, it has potent alpha-1 vasoconstrictive effects with limited tachycardia. So norepinephrine provides strong alpha-1 vasoconstriction effects and really only mild or modest beta-1 inotropic effects. This leads to improved MAP without significant tachycardia. And that can be important, right? Because patients septic shock are tachycardic, so you don't want to drive that heart rate up even higher, at least most times. If we look at the other answers, A was it increases renal perfusion. Dopamine theoretically had this mechanism at lower doses, that 0.5 to 2 micrograms per kilogram per minute. But this has been proven to not really be real, so we don't consider dopamine this increase in renal perfusion anymore. It lowers lactate production. That's not true. Epinephrine is known to actually increase lactate, but that's probably not clinically meaningful. And then D was it acts directly on V1 receptors. This is actually the mechanism of vasopressin. All right, question number 3. Dobutamine primarily affects which receptor? A, alpha-1, B, beta-1, C, beta-2, or D, dopamine 1? Pause here if you need to. The answer is beta-1. B for beta-1 receptors. Dobutamine is a synthetic catecholamine. It has strong beta-1 agonism, also known as inotropy. It does have some beta-2 agonism, vasodilation, which causes a decrease in the MAP or blood pressure. But this is a secondary mechanism. So if we go through the other options, A is alpha-1. There is very minimal alpha-1 effects of dobutamine. The beta-2 effects outrage that, so it actually causes a decrease in blood pressure. As we said, there is some background beta-2 effects, but those are secondary to the stronger beta-1 effects, and then it does not affect dopamine receptors. That would be dopamine. All right, question number 4 in the intermediate, the first intermediate question. Get ready. Question 4, a patient on norepinephrine and vasopressin for septic shock remains hypotensive. Angiotensin II is added. What is its mechanism of action? A, beta-1 stimulation, B, PDE3 inhibition, C, AT1 receptor-mediated vasoconstriction, or D, vasopressin receptor activation. Pause here if you need to. The answer is C. Angiotensin C is AT1 receptor-mediated vasoconstriction. So angiotensin II increases blood pressure by stimulating the AT1 receptors. This leads to vasoconstriction and also aldosterone release, which can increase sodium plus water retention. If we go through the other options, A was beta-1 stimulation. Angiotensin II does not do this, right? Angiotensin II is not an adrenergic or not a catecholaminergic vasopressor. Beta-1 is stimulated by norepinephrine, by epinephrine, by dobutamine, all these adrenergic or catecholaminergic vasopressors. Option B was PDE3 inhibition. This is the mechanism of Milrinone. And then option D was vasopressin receptor activation. Hopefully you guessed that this was the mechanism of vasopressin. All right, question number 4. Which of the following best explains why Milrinone is useful in beta-blocked patients? A, direct alpha-1 agonism. B, inhibition of norepinephrine reuptake. C, beta-1 agonism. Or D, PDE3 inhibition, increasing intracellular C-amp independent of beta receptors. So which of the following is best explains why Milrinone is used in beta-block patients? Pause here if you need to. The answer is D. Milrinone improves inotropy via the PDE3 inhibition pathway, and it doesn't rely on beta receptors, making it ideal for patients on beta blockers, right? So option D is the correct answer. PDE3 inhibition increases C-amp independent of beta receptors. Other options, A, direct alpha-1 agonism. This is not a mechanism of Milrinone. Norepinephrine has alpha-1 agonism. Epinephrine has alpha-1 agonism. Phenylephrine has alpha-1 agonism. Midodrine has alpha-1 agonism. B was inhibition of norepinephrine reuptake. Again, Milrinone is not adrenergic, so it does not affect norepinephrine. And then C was beta-1 agonism. Again, Milrinone is not an adrenergic or catecholaminergic inotrope, so it does not affect alpha or beta receptors. Beta-1 agonism with things like norepinephrine, epinephrine, dobutamine, even dopamine to a degree, all affects beta-1 agonism. All right, question 6. Which of the following has both inotropic and vasodilatory properties? Option A is norepinephrine. Option B is Milrinone. Option C is phenylephrine. And option D is vasopressin. Pause here if you need to. The correct answer is B, Milrinone. Milrinone improves contractility and causes vasodilation through its C-AMP, PDE3 inhibition, leading to increased C-AMP. This can cause hypotension, especially in shock states. So it does cause both inotropic and vasodilatory properties. The other options are A, norepinephrine. Norepinephrine is an alpha-1 and a beta-1 receptor agonist, so it will increase blood pressure and increase cardiac output. Phenylephrine is a pure alpha-1 receptor agonist, so it will increase blood pressure. Right, these are norepinephrine and phenylephrine are vasoconstriction, not vasodilation. Vasopressin acts on the vasopressin receptors, and it does cause smooth muscle vasoconstriction, not vasodilation. All right, getting closer to the end here. Question 7. Hopefully we're all learning together. This gets into the advanced questions. Bum, bum, bum. Question 7. A patient in decompensated heart failure is hypotensive and receiving Dobutamine. After 48 hours, the effect appears to be waning. What is the most likely explanation for this? A, bradykinin accumulation. B, hepatic metabolism inhibition. C, tachyphylaxis due to receptor desensitization. Or D, renal clearance of active metabolites. Pause here if you need to. The answer is C, tachyphylaxis due to receptor desensitization. Dobutamine tolerance develops over 48 to 72 hours. Very well known drug that has tachyphylaxis. The other options are just not correct. Tachyphylaxis and dobutamine is very classical. All right, question 8. What best differentiates vasopressin from catecholamine vasopressors? A, it increases heart rate. B, it acts on beta-1 receptors. C, it causes vasodilation. Or D, it exerts vasoconstriction via V1 receptors independent of adrenergic tone. Pause here. Answer is D, exerts vasoconstriction via V1 receptors independent of adrenergic tone. So vasopressin increases systemic vascular resistance, which increases the MAP, right? But it does this through V1 receptors. These are not catecholamine receptors. They're completely separate pathways, which is why it's a nice adjunct to norepinephrine, a nice adjunct to catecholaminergic vasopressors. Other options, A was it increases the heart rate. It does not have any beta-1 or adrenergic effects, so it does not increase the heart rate. B was it acts on beta-1 receptors, as we just said. It's not a catecholaminergic vasopressor. It does not act on alpha or beta receptors. And then C was it causes vasodilation. Just wrong. It causes vasoconstriction. All right, second to last question is question 9. A patient with cirrhosis and hepatorenal syndrome is started on norepinephrine. Why is this preferred over dopamine? A, norepinephrine improves renal perfusion without increasing arrhythmia risk. B, dopamine is ineffective in low flow states. C, norepinephrine has stronger dopaminergic activity. Or D, dopamine reduces splanchnic vasodilation more effectively. We already don't like this question because it's on using dopamine. But the answer is, pause here if you need to, A, norepinephrine improves renal perfusion and MAP more safely than dopamine. All right, this dopamine increases the risk of arrhythmias and has worse outcomes in shock. So dopamine we don't really use, just period, end point. Again, the one time which we've seen it used, although we don't really do this, is for bradycardia and hypotension, but primarily for bradycardia. But we just use epinephrine in those instances. So dopamine we don't use. Last question, question 10. In a patient receiving high-dose norepinephrine and vasopressin for vasodilatory shock, which lab or clinical marker would suggest benefit from adding angiotensin II? A, elevated serum cortisol. B, high lactate and low renin. C, elevated renin level. Or D, high sodium and low urine output. Pause here if you need to. The correct answer is C, elevated renin level. Angiotensin II is particularly useful when endogenous RAS is failing. Elevated plasma renin levels may indicate relative angiotensin II deficiency and predict a response. The challenge is we don't have a quick way to order, or shouldn't say that. We can order it, but we don't have a quick way to get back renin levels. So hopefully someday in the future, we'll be able to test renin levels to see if someone might be a hyper-responder to angiotensin II, because there's definitely patients that respond really robustly to angiotensin II and other patients that don't really respond to it. But at this point, we don't have a quick, efficient way to figure that out. That's all we have for you in this video. If this is all, confusing to you, definitely check out all of our other videos on vasopressors and inotropes. This is kind of like the capstone video comparing all of them. Sorry, episode. You might be listening to this in podcast form. So definitely check those other ones out. And if you want this study guide as well as additional practice questions, check out our Patreon page. All of our members have access to all of our study guides and additional practice questions. Let us know what thoughts, comments, questions you have down below. Stay well. Keep learning. We'll see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.